These next two questions have to deal with symptoms that you might see in clinic with eosinophilic gastrointestinal disorders. How do you understand symptoms not associated with the gastrointestinal system, such as leg pain, fatigue, and low-grade fevers? Do you think that these symptoms cannot be explained by eosinophilic gastrointestinal disorders and are associated with another disorder? In approximately what percentage of patients do you hear reports of these and similar symptoms?
So we do know that eosinophilic esophagitis is a local tissue effect, and unlike some other GI diseases like inflammatory bowel disease or even asthma, the systemic manifestations of the disease are very minimal. And that's one of the areas of research that we're heavily engaged in, is why do we see a tissue-specific effect? Now, why I say this is because it is hard to understand why patients often do complain of these other extraesophageal symptoms, whether it be the constitutional symptoms such as fatigue, or whether it be the muscle aches or arthralgias and arthritis. But we do know that these are real effects. They are observed at fairly high levels in the EOE population, and in some studies can be up to 1/3 of the patients have these manifestations. We are actively studying the cause of this. It may be that this is primary, it could be that it is secondary, and it could be that it is behavioral. There are a lot of behavioral effects of coping with having a chronic disease such as eosinophilic GI diseases that may lead to behavioral or impact on the body that leads to these general symptoms. But this is an area of active investigation, and it's very important to get to this question, the answer to this question.
The next question is about symptomatic remission. Why are some people symptomatic with clear scopes?
This is a related question to the last one, and that is a good question, another good question. But basically, we do know that there's a dissociation between symptoms and histopathologies. In other words, the findings in an endoscopy may not correlate with the clinical symptoms. And this makes researching the disease particularly challenging, and it's one of the reasons that we're working very hard during clinical trials to prove clinical efficacy, because patient-reported outcomes don't necessarily correlate with the absolute objective histopathological change that we can measure, for example, under the microscope. The reasons for this are multifactorial. It may be that we don't have proper tools for measuring the symptoms as well as the histopathology, and it may be that the patients have a post-inflammatory process that continues following the healing of the tissue and allows the symptoms to remain. So just to be specific, it's possible that a patient might have a neuropathy that's caused by the inflammation. The inflammation heals, but the nerves still don't respond normally, so they may have a dysmotility, or they could still have pain. And similar to the last question, I raised the possibility that some of these effects may be behavioral. If someone gets used to having pain every day, you may take away the pain, but they may still feel crummy because that's what they're used to. So these are all very important areas that we need to understand better, and they're under active research investigation.